Yes, السلام عليكم.
والسلام ورحمة الله.
Can you see my screen?
We can see and we can hear you. Go ahead.
Okay. So, Bismillah ar-Rahman ar-Rahim. I'm Samah Fageeh. I'm an F2 abdominal imager in King Abdulaziz Medical City. Today, I will show you a few interesting cases that came to us in our daily practice. We will use the polling, as we said before, as with Dr. Hannah lecture. I will show the cases and I will ask you what's the most likely diagnosis, and I will provide some questions, follow-up questions about the cases. I will do the polling. I'll give you 15 seconds to answer, and then I will share the results with you. And I will discuss the diagnosis and differential diagnosis of each case. So let's begin. This is our first case. This is a 30-year-old female with 2 months history of abdominal pain, vomiting, and fever. I'm providing the CT cuts, the diffusion weighted images, T2 weighted image, and a bit CT axial image. So what is your most likely diagnosis? I will launch the poll now. And you can vote. Okay, I'm ending the polling now. I will share the results with you. So most of you goes with the Erdheim-Chester disease. Some go with the other differential diagnosis. So let's see. Let's discuss what are the imaging features in our case. First, we have the CT images showing bilateral perinephric soft tissue involvement or soft tissue ring-like densities with interposing fats in between. These soft tissue density show low T2 signal intensity, and they don't demonstrate diffusion restriction. We have additional finding, which is the anterior abdominal wall soft tissue density or thickening, which is also showing hypermetabolism in the BIT-CT, similar to the perinephric soft tissue. So it's an actual soft tissue lesion or abnormality involving the anterior abdominal wall. So let's go through the differential diagnosis. And our aim here, our category is the perirenal, so ring-like soft tissue density. And what's the most likely diagnosis? So let's go with the first differential, which is the extramedullary hematopoiesis. In patients with extramedullary hematopoiesis, as you can see in this example, we have the similar appearance of perinephric soft tissue ring of soft tissue density surrounding the kidneys bilaterally. But we have other ancillary findings that support the diagnosis of EMH. These are the presence of splenomegaly with multiple hypodensities, the presence of soft tissue infiltration of other organs, like here in the perihepatic or periportal area. We have also multiple portahepatis lymph nodes. And on assessment of the bone window, we can see there is diffuse sclerotic involvement of the bones. So this is likely it's a displacement, or I mean, there is deposition in the bone, and there is decrease in the production of hematopoiesis that causes the RBCs to be produced in other locations rather than the bone, like in extramedullary areas, like the liver, spleen, and perinephric areas. So the clues here for the differential for the diagnosis of extramedullary hematopoiesis is the involvement of multiple locations that are specific for the extramedullary areas of hematopoiesis, and the presence of risk factors. So this patient has primary disease of myelofibrosis that is replacing the bone marrow and causing the extramedullary hematopoiesis. Other risk factors that also include the lymphoma or leukemia patients, and other lymphoproliferative diseases. Also, to be sure, we can ask for sulfur colloid scintigraphy to show the activity in these in this extramedullary hematopoiesis. Specific characteristic finding in these diagnoses is the presence, if there's presence of macro or microscopic fat. But in this example, we cannot see any well-defined fat globule. Okay, moving on to the next differential diagnosis. It's the IgG4 related disease. And renal involvement in this disease occurs in 35% of patients. However, its isolated involvement is rare, and it occurs in only 6% of cases. And in IgG4 related disease, we have multiple patterns of involvement of the kidneys. And the most common pattern is the bilateral round or multifocal-like appearance of involvement of the kidneys, as we can see in this case. We have other pattern, which is the diffuse enhanced involvement of the parenchyma of the kidney, as you can see in this example. The third pattern is the involvement of the periurethral or pelvic areas with soft tissue density lesions that can be unilateral or bilateral, as we can see in this case. It's of low T2 signal intensity, and it may or may not cause hydronephrosis. And the involvement of the renal pelvis can also be as wall thickening only, not like soft tissue. It's mainly of a wall thickening that resemble pyelonephritis. As in this patient, we can see bilateral involvement and additional finding of focal pancreatitis. The last appearance is like our case, the involvement of the perinephric tissue with soft tissue density. However, in this case, we see a clue for the diagnosis, which is the involvement of the periaortic area causing retroperitoneal fibrosis and bilateral perinephric involvement. So how can we diagnose IgG4 related disease? Is by looking at the other associated manifestations of pancreatitis or biliary cholangitis. And of course, we can assess the IgG4 level. Moving on to this third differential diagnosis, which is the lymphoma. Lymphoma also involvement can be with multiple patterns. One of them, which is the perinephric involvement, like our case. And the perinephric involvement is usually associated with other areas of involvement. Like in this case, as you can see in the upper row, we can see the perinephric involvement similar to our case. However, we can see other organ involvements in the form of splenomegaly and multicompartmental lymphadenopathy, causing the sandwich sign. And in the ultrasound, we can see the characteristic very hypoechoic appearance of the lymphoma. Other patient with the lymphoma showing only unilateral perinephric soft tissue density and ipsilateral enlarged inguinal lymph node. Okay, so what are other additional differential diagnosis of the perinephric soft tissue lesions is amyloidosis. Amyloidosis is a deposition disease, and it can be primary or secondary to other diseases like autoimmune diseases or lymphoma. So in this patient, we can see at his initial presentation, there were soft tissue lesions infiltrating the perinephric areas and the retroperitoneum, mesentery, and omentum. And upon follow-up, these lesions get calcified. First, showing spicules of calcifications or rim-like calcifications with, and over time with more progressive, more calcifications involving multi-compartments. So the clue for diagnosis of amyloidosis is the presence of calcifications that are usually progressive and the diffuse infiltration. We have also another rare differential diagnosis that is similar to the appearance of mainly IgG4 related disease or lymphoma. That is called the Rosai-Dorfman disease. This disease is a rare benign idiopathic proliferative disease. It involves the histiocytes and causes massive lymphadenopathy. The lymphadenopathy mainly occur in the cervical region and other nodal disease. The extranodal sites of involvements are less common and may involve the skin or bone, and renal involvement is very rare. It occurs in only 4% of cases. However, if it occurs, it will resemble other differential diagnoses, like we can see in these cases. we can see the rend-like soft tissue density in bilateral benefic regions with some lymph nodes. We can see here the pattern similar to the IgG4 related disease with peripelvic involvement, and we can see here a pattern also similar to lymphoma with a large exophytic mass with lymph nodes. So if the patient has known diagnosis of Rosai-Dorfman disease, this will be easy to be diagnosed. We should only be familiar with the involvement of the kidneys in these patients. However, if it's not diagnosed before, this will need tissue sampling. Okay, so moving back to our case. So we have discussed the differential diagnosis that is written here. Lymphoma, in this case, I wouldn't go with the lymphoma because of the non-presence of diffusion restriction in the perinephric soft tissue. Also, there is no other ancillary features or other organ involvement, no splenomegaly and no lymphadenopathy. Extramedullary hematopoiesis is still a consideration in this case because of the perinephric involvement, even the soft tissue involvement. However, if you can see here the bone marrow in the T2 weighted images, it's of normal signal intensity. It's not low to consider presence of anemia or a myeloproliferative disease. So it could be one of the differential diagnoses, but it's less likely. IgG4 related disease is also within the differential. However, I cannot see the biliary or pancreatic involvement. So we're remaining with the Erdheim-Chester disease, and we didn't talk about it yet. So in this patient, we reviewed the other patient jacket, and we saw the other imaging of the patient. So the patient had skeletal lesions and brain and chest imaging findings. Now, I will run the poll again to see if you have changed your mind about this question, and I will see your final diagnosis. Okay, so you can vote now. Okay, so now you're going mostly with Erdheim-Chester disease. Only few, they picked up lymphoma. So here, the skeletal manifestations is leading us toward Erdheim-Chester disease. These findings are represented by spicules of sclerotic appearance of the bones involving the metaphysis and diaphysis of the long bones, especially here the tibias, both tibias. It's not that well shown maybe in your screen. However, if you correlate it with the BIT images, it shows nicely the hyperactivity in these areas. And in the brain, we see an extraaxial meningioma-like appearance of extraaxial lesion in the left frontoparietal region. And in the lung, we see smooth intra and interlobular septal thickening. And in this young patient and without history of cardiac disease, it's less likely to be related to pulmonary edema. So putting it all together, the final diagnosis is likely to be Erdheim-Chester disease. So Erdheim-Chester disease is a rare, sporadic, non-LCH proliferative disorder with systemic involvement. Why didn't we go here with lymphoma? First, about the MR images, there is no diffusion restriction, no other lymphadenopathy, and no splenomegaly. The characteristic skeletal appearance is less likely to be with lymphoma. The lymphoma will cause more the bone lesions to be aggressive with permeative reaction, periosteal reaction. So this is less likely to be lymphoma. Okay, moving back, I will ask another question. What is the most involved extraosseous site in Erdheim-Chester disease? And I will launch the poll for you now. Okay, ending it now. Sharing the results with you. So most of you said it's skin involvement. Others said it's retroperitoneal involvement. Okay, so the correct answer is the retroperitoneal involvement, including the kidneys. It's the most common extraskeletal site of involvement. Also, the skeletal involvement is very constant. It's almost constant finding in these patients. After the retroperitoneum, it's followed by the cardiovascular, CNS, and skin involvement. And we have here another companion case of Erdheim-Chester disease, showing the perinephric involvement, which is here more specific of the disease due to its hairy-like appearance with fluffy appearance into the perinephric fat, with the interposed fat in between, giving the hairy kidney sign. We have also here a characteristic appearance with periatrial soft tissue nodules, and in the brain of this patient, we had the thickening and enhancement of the pituitary stalk. Okay, moving on to the next case. This is a 47-year-old female with abdominal pain. What is your most likely diagnosis? I will launch the ball. And you can vote. So is it granulosa cell tumor, fibroma, fibrothecoma, ovarian metastasis, or sclerosing stromal tumor? I'm ending the polling now. Most of you goes with granulosa cell tumor. Others go with sclerosing stromal tumor. So let's see, what do we have here? We have a large left ovarian lesion that is predominantly solid, and the solid component showing low T2 signal intensity with multiple internal areas of cystic degeneration with hemorrhagic component and fluid level. The T1 images confirm the presence of hemorrhagic component, and both contrast images show avid enhancement of the lesion. So we are dealing with a solid ovarian lesion that is of low T2 signal intensity and of hypervascularity. So let's go through the differential diagnosis first. The first thing that comes in mind is the granulosa cell tumor. And this granulosa cell tumor, because it always occurs with hemorrhage, they have tendency to bleed, and they have tendency of developing hemorrhagic changes. So we have this patient with CT findings that show the active bleeding of a large left ovarian mass. This mass is also associated with endometrial thickening that is characteristic for this type of tumor, which is estrogen producing. We have the MRI images here in this patient, in another patient that is similar to our case with heterogeneous T2 signal intensity, internal hemorrhagic component, and high T1 signal intensity. Maybe the only difference between this and our case is the solid component here shows high T2 signal intensity. Our case showed low T2 signal intensity. The other differential diagnosis is the sclerosing stromal tumor. And these tumors, they differ from our case by multiple manifestations. First of all, the age. The age is usually younger than 30 years of age. And it's usually a complex cystic and solid lesion with the solid component is mainly peripheral, showing high T2 signal intensity. The enhancement looks like our case with hyper enhancement. However, it has a characteristic appearance of enhancement, which begins in the periphery of the lesion and then causes centripetal filling in the delayed phases. So these are different patients, one with CT and one with MRI, showing the same appearance of the peripheral hypervascularity. Okay, moving on to other differential diagnosis. Regarding the internal hemorrhagic component or leveling that we saw in our case, this lesion is similar to that in the form of complex heterogeneous lesion with internal solid component that is of low T2 signal intensity and also leveling in the T2 and T1 weighted images. However, these lesions are usually more complex and containing more cystic component than our case. And the leveling component will be of low signal intensity in T2 and T1 weighted images because it involves thyroglobulin. And it's low in both T1 and T2 weighted images. These lesions present unilaterally in reproductive years and sometimes present with thyrotoxicosis. Other differential diagnosis is the ovarian metastasis, and these most commonly come from the stomach, other locations from the breast, colon, or appendix. These lesions are likely bilateral, most likely comes bilateral in 60 to 80% of cases. They can show low T2 signal intensity, and they can show avid enhancement like our case. Other differential diagnosis of low T2 signal intensity masses is the fibroma or fibrothecoma. And I selected here the fibrothecoma because it's more similar to our case because of the thecoma part that shows the cystic or high T2 signal intensity and the fibrous part that shows the low T2 signal intensity. However, it's different from our case due to the mild enhancement. And if we provide diffusion, it will show no diffusion restriction. Okay, so let's go back to our case. Our case, we have the solid component that is low T2, and we have the hemorrhagic leveling, and we have, as we said, the hypervascular component. So digging more in the history and more in the images, we have other additional images for the same patient. So what do you think the most likely diagnosis now? You can vote now. Okay. I will share the result with you. Most of you say it's mixed syndrome. Some say it's ovarian metastasis, and some say it's granulosa cell tumor again. So let's see, what do we have in these additional images? We see generalized subcutaneous edema in the form of anasarca, ascites, and passive hepatic congestion. We have also selected MRI images of the heart showing a low signal intensity jet at the expected location of the tricuspid valve. So upon assessment in the dynamic images, this was regarded as tricuspid regurg. So in a patient with a solid ovarian lesion that is hypervascular with hemorrhagic component, and we have cardiac involvement or cardiac disease with generalized anasarca, what comes in mind is the carcinoid, ovarian carcinoid with the ovarian carcinoid syndrome. So I tricked you here. I wrote it as ovarian metastasis from VI malignancy, but it was a primary carcinoid tumor. We can go with this one. It's maybe a carcinoid, primary carcinoid tumor of the small bowel with ovarian metastasis. However, our case was a primary carcinoid tumor. They represent less than 1% of all ovarian and all carcinoid tumors. However, they are the most likely involved sites in the GU tract in females. It's unlike the small bowel carcinoids, the bronchial and the ovarian carcinoids can produce carcinoid syndrome without the presence of liver metastasis because they bypass the liver. The venous drainage, they bypass the liver and they go directly to the systemic circulation. So the mediators and the serotonin go directly to the systemic circulation and produce the carcinoid syndrome. The carcinoid syndrome affects multiple organ systems in the form of, it involves the GI tract and in the form of diarrhea, the skin in the form of flushing, and it involves also the heart, mainly the right side of the heart, with tricuspid regurg and pulmonary stenosis. Sometimes ovarian carcinoids also cause constipation due to they produce hormonal peptide. As we said, it could be primary or secondary metastatic. The metastatic carcinoid, it will be bilateral and more aggressive. So the clues for diagnosis in this case is the low T2 signal intensity, which is against the other 6 quartz stromal tumors like granulosa cell tumor. The presence of hemorrhage is also a supportive feature. The presence of hypervascularity, also with the presence of low T2 signal intensity, that is against fibrotic tumors, and it goes mainly with carcinoid tumor. And if we see also the manifestation of carcinoid syndrome. Okay, so moving on to the next case. This is a 35-year-old known case of CML, presented with abdominal pain. I will launch the polling. What is your most likely diagnosis? Okay, I will end the polling now. I'm sharing the result with you. Most of you said it's splenic leukemia. Others are divided into extramedullary hematopoiesis and infection. So this is actually a non-specific finding. We can see here the multiple splenic and hepatic well-defined small hepatic and splenic lesions, and with a large focal mass in the spleen that is showing active bleeding or hemorrhage. So when we saw this case, we said this is a leukemia infiltration with bleeding. The patient was unstable, and he was splenectomy was performed, and the pathology was extramedullary hematopoiesis. All these lesions in the spleen was extramedullary hematopoiesis, and one has ruptured. So it's a non-specific findings. I just wanted to let you know that are several causes of non-traumatic splenic ruptures. Of those, the most common are the hematological malignancies. And of those, the non-Hodgkin lymphoma is the most common, followed by myeloproliferative disorders, and then leukemia. Infections are also one of the common causes of splenic rupture, and infection can occur in these type of patients due to immunocompromised status. Other causes of rupture is the inflammatory disease, medications, or mechanical causes or idiopathic causes. There were only few reported cases of splenic rupture due to extramedullary hematopoiesis that were occurring after stem cell transplantation, and there are also few reported cases of splenic rupture due to HELLP syndrome. So there is no specific features. The presence of multiple locations and the risk factors could lead us to the diagnosis of extramedullary hematopoiesis. If we can see small fat component, this will give us the diagnosis. But if not, it will be a discussion differential diagnosis. And just to know that extramedullary hematopoiesis can also cause splenic rupture. Okay, I'll skip this last case because of the time. So these were my cases. I hope you enjoyed it. I would like to give a special thanks to Dr. Fawaz Al-Harbi and Dr. Rad Madkhali for their help in my presentation. And I would like also to thank Dr. Badr Al-Mutairi for giving me this chance and for supporting us always. And thank you all so much